What's up, everybody? I'm excited. It's another ICU video. It's analgesic agents in the ICU today. For analgesic use in the ICU, there are really two classes to use: opioids and non-opioids. So to start off with the opioids, fentanyl is the most commonly used opioid in the ICU, and that's because it does a great job at pain relief, really without any adverse effects that the other opioids have. It's very lipophilic, so it causes a rapid onset of action. Morphine is metabolized in the liver and excreted through the urine. There are two active metabolites that accumulate in renal failure. 3-glucuronide produces central nervous system excitation, myoclonus seizure. 6-glucuronide is responsible for the analgesic effects. And it's very important that if you have a renal failure patient and you're using morphine, the dose needs to be reduced by 50%. Because morphine has a profound histamine release and response, it causes hypotension. Hydromorphone is a morphine derivative. There's really no evidence of that it's better than morphine. There's no really clinical benefit to choose it over morphine. The saving grace is, of course, that there's really no dose adjustment in renal failure patients. And remfentanil is a short on, short off agent. Its metabolite is broken down in plasma, so there's no need to make dose adjustments in patients with compromised liver or kidney function. Because it has a quick on and off action, the effects can wear off within 10 minutes of discontinuation. There is a small risk of opioid withdrawal. And then meperidine is broken down into normepiridine, which is slowly cleared out through the kidneys. It can cause central nervous system symptoms such as delirium, seizures, and because it is common to have renal insufficiency in ICU patients, it's not really commonly used. Switching over to the non-opioid analgesics, we primarily use NSAIDs, and then we treat a little bit of neuropathic pain as well. So in terms of our non-steroid anti-inflammatory drugs, ketorolac is a big one that we use. We primarily prefer the intravenous route to the intramuscular route. That's just because the IM route can cause hematoma, so we prefer the IV route. And then you want to decrease the dose by 50% in elderly or those who weigh less than 50 kilograms, and you want to use it for no greater than 5 days of use. That way you can avoid things like GI bleed and other NSAID adverse effects. Next is ibuprofen. There's really no limit to treatment duration, which makes it, in that sense, better than ketorolac. You want to use a maximum limit of 3.2 grams daily. And then acetaminophen is very similar. However, it's not really used for anti-inflammatory properties. It's better for antipyretic properties, and the maximum limit is 4 grams daily, and you want to avoid hepatotoxicity in these patients. And then for neuropathic pain, we have two medications that we use, gabapentin and carbamazepine, and both of these are given enterally through the mouth. And here we're just summarizing the adverse effects of analgesic agents in the ICU. Opioids, you can take a look at this in your free time versus non-opioids. I just wanted to highlight the big ones. The non-opioids is mucosal injury, upper GI bleed, and renal insufficiency. And the opioids have things like respiratory depression, hypomotility, urinary retention. And that's it for this video. Thank you all for your time. Reach out if you have any questions.